This program is brought to you by Emory University.
Good morning, everybody. Happy Friday. Thank you so much for joining us for Fellows Conference today. This morning we have Dr. Hassan Chami, who will be speaking about myocardial viability and ischemic cardiomyopathy. Hassan did his medical school and part of his residency training in Beirut and then joined us here at Emory. And now we are very lucky to have him as a second-year fellow. So the floor is yours, Hassan.
Thank you, Dr. Coley. So good morning, everyone. So I will be going over a case, and we will end up with how did we manage this case. Throughout the presentation, we'll be discussing some of the evidence on viability assessment and outcomes. So we have Mr. B, who is he's an 84-year-old male patient, basically presented to the clinic with chest pain. Let me hide this. His past medical history include CAD with a prior STEMI in 2022, and for which he had an Impella-assisted PCI to the LAD and the left circ. He also had reduced ejection fraction heart failure from ischemic cardiomyopathy, and his last echo showing 25 to 30% EF back in 2023. He also had a CRTP placed. He, among other medical problems, he had permanent AFib, sinus syndrome, hypertension, CKD, OSA, hypothyroidism, and stage 3 melanoma, for which he had immunotherapy. So in terms of his chest pain, it basically started over the past month and it has been stable. Described it as pressure-like, 6/10 in severity. It radiates to the bilateral chest and shoulders, and it's only exertional. So whenever he stands up, walks back and forth in the house to help his wife, it starts happening. And then it resolves after a few minutes of rest without any other associated symptoms. In terms of his other, like his medications and labs, he's on a pretty decent regimen for heart failure. He takes Entresto, metoprolol, spironolactone, and he's on anticoagulation with Plavix for the CAD and statin. And his labs basically unremarkable. His kidney, except for like his creatinine is 1.65, which is on baseline. And his BNP is elevated, with lipid panel seems to be under control. In terms of his EKG, the important part that from our perspective for the presentation is the Q waves and the inferior leads, suggestion of a prior myocardial infarction in the inferior wall. But other findings include like bi-V pacing, among others. So moving forward I mean, these are the best echo images I could get, but I will play these videos for you to review. So, I mean, obviously reduced EF, some posterior wall, inferior wall, akinesis or hypokinesis, septal wall motion is abnormal, probably from conduction versus like myocardial, like a wall motion abnormality from ischemia. I mean, and this in the short axis view is mostly like seeing the inferior wall is down. Okay. Then in terms of, I mean, I added also some of the other views just to have an insight on what we're dealing with. So his wall, like most of his walls are down. He has global hypokinesis, but mostly in the inferior wall, there's akinesis, and also there's severe septal hypokinesis. So in terms of further workup with his chest pain, the decision was to proceed with the left heart cath. And I also play some of the cath films. So showing the left system, the right system. Obviously had significant disease in both systems, with like total occlusion of the RCA distally, If you can see it here, same thing. Let's see. So he has basically multivessel disease with instant restenosis and the prior stents. Some of them were not, like there's no instant restenosis. So the overall cath report was showing like a left main proximal LED 0%. The mid LED had a CTO with instant restenosis after the diagonal branch, and the distal LED usually is filling from left to left collaterals. D2 is showing 90%. The proximal circ is 0% with 0% instant restenosis, and the distal RCA have a, as I said, CTO, and it fills from left to right and right to right collaterals. So based on his symptoms and his wall motion abnormalities, his cath films with these CTOs, the decision was to proceed with viability study to see if we have some room for revascularization to improve his EF. So from here, we're going to go over my myocardial viability assessment, and I'm going to try to define myocardial viability with more of understanding on pathophysiology of myocardial stunning and hibernation. And we'll have just a brief overview on the various techniques used for viability testing, with my focus mostly on going to be on FDG, PET, and kind of introduction on cardiac MRI. And then we're going to go over some of the evidence behind using, whether it supports or it doesn't support viability testing. So the whole idea about myocardial viability, opposed to what the prior thought in the old days, like many decades ago, that severe LV dysfunction is irreversible process. Now we know that it's not always irreversible, and the dysfunction itself can result from myocardial necrosis and remodeling, myocardial hibernation, or repetitive myocardial stunning. And most of the time, patients have an admixture of all the three entities. And from that idea, the thought becomes like whether revascularization of a viable myocardium could potentially improve LV function and symptoms, also outcomes afterwards. So from here is the interest became more and more in assessing viability. So in terms of viability, what do you mean by viable myocardium? So from the term itself, viable means living. So it includes a normal and contractile myocardium, but we know that it also includes a hypocontractile and hypokinetic, in which the cells are still viable, but they are struggling for blood supply, and this will result in contractile dysfunction. So when we look at viability, we usually link it to contractile recovery. So does this area of myocardium has the ability to recover its contractile function, meaning indicating that the cells are viable. So we think about it as a normal contractile viable myocardium or a dysfunctional ischemic viable myocardium, which is usually what we are testing for. And these usually, like clinically, like on echo, for example, these could look at hypokinesis, akinesis, and reduced ejection fraction, and could be symptoms as well. So the main point is we're basically testing for hibernating myocardium when we are testing for viability. Along the same spectrum, myocardial stunning and hibernating myocardium basically are adaptive mechanisms of the heart in response to myocardial ischemia. The difference is for stunning, basically, it's more of a delayed recovery of the regional LV function after a transient period of ischemia that was followed by reperfusion, which is usually common after PCI. And as you can see in this figure, like when there's an acute ischemic episode, there will be drop in perfusion, and with the perfusion contraction matching or coupling, there will be decrease in the regional wall motion until we can reperfuse the territory again, and there will be increase in the blood flow, but the return to the basal, to the normal function might take a little bit more time than in comparison to the perfusion. Similarly, hibernating myocardium is also a result of myocardial ischemia, but it's more of a adaptive rather than an injurious response of the myocardium. So in which the viable but dysfunctional myocardium arise from more prolonged myocardial hypoperfusion at rest and in the absence of clinically evident ischemia. So in hibernating myocardium, usually there will be like multiple bouts or repetitive ischemia resulting in a chronic hypoperfusion. And this will lead to gradual decline in contractile function as the heart is trying to adapt to this low coronary blood flow. And at some point, if you do restore blood supply at the right time, you might have increased or gradual increase in function. So in terms of the prerequisite of both hibernation and stunning is basically reduction on the myocardial blood flow, which is not just a simple, like you have an artery, it's blocked. It's a more complex process, and you have to also like there's a lot of contribution from collaterals, plate morphology play part into it, and also abnormal microvasculature is also involved. But if we let's say we ignore all these factors and we look just at the degree of the stenosis, so if the coronary stenosis is approximately 40%, it's usually does not like alter the maximum blood flow, and there will be the coronary flow reserve will remain normal in these patients, and there will no change in their function, in their systolic function. And if it's between like, let's say 40 and 80%, the resting myocardial blood flow will remain intact, but the maximum blood flow will be diminished, especially when there is increased oxygen demand as in exercise. And this will be reduction in the resting and the coronary flow reserve, hence reduction in systolic function. And this is where repetitive and hibernation usually occur. In the presence of a high-grade stenosis, the flow that was normal at rest is now also diminished, and this will be, if we regard this in terms of a perfusion contraction matching, then myocardium that at one time is stunned, once there is more a drop in the coronary blood flow, it will become hibernating and so on. So it will be going back and forth between repetitive stunning and hibernation. So in this regard, we view these two terms as a spectrum or a continuum of adaptive mechanisms. And in terms of other adaptive mechanisms of the myocardium, something called ischemic preconditioning, where it's closely associated with stunning and hibernation, and it's basically a brief period of ischemia that tries to protect the myocardium from a subsequent more prolonged period of ischemia. In this regard, we view the heart as a smart organ basically, and it tries to adapt to several degrees of reduced coronary blood flow, and to try to maintain programmed cell survival instead of programmed cell death as we see in other organs. So what do we need to have a viable myocardium? So basically, we need to have an intact sacroilimbal function that would maintain the electrochemical gradients across the cell membrane, preserve metabolic activity to ensure the availability of high energy phosphate production, and obviously adequate myocardial blood flow to deliver the substrates and wash out the metabolites of the metabolic process. So knowing that, it's important to understand the metabolic activity of the cardiac myocyte because that would be the one of the focus on how to test for viability, basically. And we know that the normal heart, 2/3 of energy is derived from fatty acids, and almost like a third is from glucose. And but it depends on whether you're fasting, you're not fasting, what's your blood sugar, etc. This could be affected. But in general, ischemia shifts the myocyte metabolism preferentially to glucose from fatty acids. And this is important because in that regard, we can say, like the uptake of glucose analog, like FDG, for example, in a dysfunctional myocardium indicates metabolic activity and thus viability. So understanding the requirements for viability would allow us to kind of check that how many the techniques to assess myocardial viability. So many techniques are available. Some of them are not used anymore, like the thallium imaging. I think thallium has been pulled out of the market for many years now. The most important ones are FDG PET, contrast MRI, or like just cardiac MRI, whether with or without dobutamine, dobutamine echo. I've never seen SPECT system EB imaging in our Emory system. I'm not sure if we do this here, but at least at Emory Midtown they don't do it, or at the VA. VA might still do it, but they use mostly tetrafosmin or technetium. So each one has its different benefits and the way they assess viability depending on the tracer that we use and the prerequisites for each study. Like for example, the FDG imaging require like is not affected usually by the sacroiliac membrane. It's mostly focused on the myocardial metabolism. Thallium, for example, needs an intact cell membrane, and so on. So in terms of sensitivity and specificity of these techniques, usually in this type of images or of studies, the specificity and sensitivity, like when they want to say what is sensitive and specific, is based on whether there's a functional recovery of the myocardium after the test. So that's basically the gold standard. Like, was this test able to predict that this area of the myocardium will recover or no? And that way we could tell this was a sensitive or a specific test. So in this figure, there's a comparison of the sensitivities and specificities, and it's important to notice that, for example, like the dobutamine echo in the yellow here, we can see it has more specificity and less sensitivity compared to the other nuclear-based techniques, which are more sensitive and less specific. And this is most likely because we are comparing it to functional recovery. And with the dobutamine echo, we can see the functional recovery, or like the increased contraction while doing the test. So you could tell immediately if it's improving or not. And furthermore, like more studies or like a meta-analysis that included almost 3,000 patients in 105 studies showed like these were able to extrapolate these sensitivities and specificities for each study. And again, as you can see, like with the nuclear-based techniques, they are usually more sensitive than specific. And when you use like contractile reserve techniques, which is like the dobutamine echo or the dobutamine cardiac MRI, specificity goes up. Sorry. So I will be talking briefly over like FDG, PET, and cardiac MRI, just for the sake of time. So in terms of FDG PET, it's probably the only viability study I've used, other than cardiac MRI, of course. But basically, FDG allows us to study the myocardial metabolism and function. And usually what happens is the FDG accumulates in the heart basically in proportion to the utilization of the myocardial cells. So, and it competes with the glucose for the hexokinase. So, and then it undergoes FDG. It undergoes phosphorylation into FDG6-phosphate, which is not further metabolized, resulting in trapping and slow dephosphorylation. This will allow us to have time to take images and then be able to detect viability. So in general, uptake of FDG indicates viability, but if it's not, if there's no uptake, this doesn't mean the opposite. It could be a non-viable tissue, but it could be also that the myocardium or that tissue is utilizing substrate other than glucose. So in that regard, every effort should be made to force the myocardium to utilize only or at least primarily glucose. And this is influenced by metabolic and the hormonal milieu. So that's why we have protocols in order how to do it, so that we ensure that glucose is the only available fuel for the heart. So, and this is usually entail, aside from the specifics of each protocol, like the patient will be asked to be fasting, then we will give a glucose load, plus or minus insulin, depending on the blood sugar, and then we inject the FDG tracer or the FDG 18, and then we can obtain our imaging. So preparation is very important. Otherwise, we will have like not artifact, but like diffuse uptake, and we would miss the study. And usually the study is a combination of a rest myocardial perfusion and the metabolic imaging. And the rest imaging could be done with SPECT or PET. And then once we do the FDG, we use PET for imaging. And and when you do the rest myocardial perfusion imaging, if you don't have any fixed perfusion defects, then all the myocardium is basically viable, and you probably don't need to do a viability testing. You could still do a stress imaging, which would indicate inducible ischemia, hence viability. So you don't need that study anyways. And three patterns would the FDG study would give us three patterns, which is normal, match, and mismatch patterns. And as you can see in the figure, like this one is using ammonia with PET and comparing it to the FDG. So normal would be like uptake in all the myocardium, indicating viability. Mismatch is showing like there's decreased uptake here, and then on the FDG study, there's improved uptake, indicating metabolic activity, which is usually what we are looking for. And this is basically what hibernating myocardium looking. And if there's matching, meaning the same areas, there's no FDG uptake and no perfusion, that usually indicate myocardial infarction from prior ischemia or prior myocardial infarction or scar tissue. Moving forward to the second modality that I will be talking about is cardiac MRI, where we have several techniques that could be used with cardiac MRI. These include LV end-diastolic wall thickness evaluation, LGE imaging to check for transmural extent of MI, and also we could do the butyramine cardiac MRI, checking for any inotropic reserve of segmental contractile function. So in terms of just briefly on each one, the end-diastolic wall thickness usually has limited prediction for functional recovery after revascularization, and the cutoff they use is like 5.5 millimeter, was shown to have like a 94 sensitivity and only 52% specificity. And this could be attributed that the wall thickness is basically a structural variable, and it does not really assess the physiological responses of the myocardium. And there is a wide variation between individuals and even between different myocardial segments in the same individual. So, but it's one of the methods we could use. On the other hand, in terms of late gadolinium enhancement imaging, usually the signal from a normal myocardium is null or suppressed, and In patients with CAD, the dysfunctional myocardium with normal or null signal intensity, this indicates myocardial stunning and hibernation and the absence of infarction. If and in patients with chronic MI, for example, the LGE characteristically involve the entire transmural extent and also or the subendocardium. So basically what we are looking for to see the extent of the late gadolinium enhancement and how much is taking up from the wall. And according to that, we can try to predict like if this tissue will be viable after revascularization, will it recover its contractile function. So in general, if there's like an akinetic segment with no or minimal subendocardial infarction, they have usually more than 90% chance of segmental recovery. Segments with more than 50% transmural extent of infarction, usually they have less than 10% chance. If it's less than 50%, it's hard to predict the exact recovery. And in these cases, usually using an inotropic reserve could be helpful to see if that function improves after we give the butyrin. An example where cardiac MRI is used, before, like as you can see, before revascularization, there's like you can see the wall thinning, and then indicating some degree of hibernating myocardium. And then once you do revascularization, you could notice that the thickness increased in the myocardial wall, and even on the EKG, the anterior septal Q waves kind of start to resolve. So it was also reflected on the electrical testing. So all of this to say, does it really help to do a myocardial viability assessment? Does it change outcomes or improve survival, for example? So historically, in the old days, back in the 90s, there was some evidence on its on the benefit of viability assessment before surgical revascularization. So in this study, most of these studies are like retrospective studies with a small number of patients. So we cannot draw a lot of conclusions out of them nowadays, and we definitely need more studies. But like, for example, this study had studied 21 patients where they checked viability 8 weeks before 8 weeks before CABG, and then 8 weeks after they assessed the EF. And as you can see, for patients who had viable myocardium preoperatively, at 8 weeks, they had increased in the ejection fraction. And in these patients in group A, for example, there was like more than 7 segments that are viable. When you have less than 7 segments viable in group B, there was no improvement in ejection fraction. So that basically told us that, yeah, if you have more viable tissue, if you do revascularization, there will be improvement in function. Moving forward in the early 2002, this meta-analysis of almost 3,100 patients from 24 observational studies basically showed that among patients with viability, revascularization improved death rates compared to medical therapy. And in patients with non-viable myocardium, basically there was no difference in terms of mortality. And similarly, they checked the opposite. They checked like in terms of the groups who got the revascularization, if they had a viable myocardium, they had lower death rate. If they had non-viable myocardium, they had increased rates. So basically proving almost the same point. But there was a significant bias that limits the generalizability of these findings, but these were the available data at that time. And more recently, the Part 2 trial was the only trial basically on viability guided management, in which they tested 430 patients with severe LV dysfunction, randomly assigned to the management assisted by FVG PET versus standard of care. And they had similar outcomes in both groups over within 1 year. Then later on, they did the long-term follow-up outcome study over 5 years, which also did not show that PET-assisted management reduced cardiac events compared to standard care. Moving forward to the known stitch study, where they did the stitch viability sub-study, and again, it also patients who underwent viability or who had viability or did not have any kind of difference in terms of outcomes with that supports CABG can improve outcomes in patients with viable myocardium. And this one is like non-randomized, and the technique they used for viability testing was SPECT and the butyramine stress echo, but they didn't use PET or MRI. So a lot of questions about the utility of the stitch viability study to kind of be able to draw conclusions out of it. But overall, none of these the stitch viability study basically did not support the use of viability testing. And most recently, the sub-study or the pre-specified secondary analysis in the REVIVE trial also assessed viability and outcomes. And similarly, it didn't really show benefit of viability study. And this was conducted on 87% of patients from the REVIVE trial, which tested PCI and ischemic cardiomyopathy with like LV dysfunction, basically. And there was no improvement in outcomes. So far, we don't have any really good evidence to support the use of viability studies. The only evidence was like from old data with small number of patients, non-randomized, mostly retrospective, and in these days there was like no adequate GDMT, so we really don't have enough evidence. So in the current guidelines, they don't really have any specific recommendation for or against viability testing. And it is probably important to individualize our approach in terms of like who should get it before revascularization or who doesn't. The point is also we don't know exactly if, like, let's say you have a viable myocardium, like you don't have viable myocardium, would you still benefit from revascularization? So improvement in EF might not be the only factor that plays part into better outcomes. Because like, for example, in the STITCH study, the better outcomes basically were from reduction of acute myocardial infarction or future events, and from future events. Revascularization might help reduce future events in the remaining viable myocardium. So, and that could be translated into improved outcomes. So regardless whether you have viability or non-viability, you might still benefit from revascularization, especially if we're talking about open heart surgery or CABG, because it's a more complete revascularization compared to PCI, which doesn't take into consideration the plaque state or the whole vessel, and it will be more complicated procedures. At the same hand, we would think about CABG, it's also a high-risk procedure, so it's better to individualize our approach when we think about revascularization for these patients. So going back to our patient, he underwent the FDG study, and basically we can see the images, like these are the rest images, the rest perfusion, rest MPI, and these are the FDG uptake images. So I mean, you could see some improvement in the some FDG uptake in the inferior wall. It's not that significant, but it will be more clear with the next images. So here we have the perfusion defect, and this is when we applied the FDG, and you could see that there's some FDG uptake in these areas that was not present on the MPI, which indicates there's some metabolic activity and hence viability. So the results basically was shown to be like 35% severe apical, inferior, and inferior and lateral perfusion defect, which is suggestive of prior myocardial infarction versus hyponating, because it's a rest study. Then once we did the FDG study, it showed a mild to moderate 6 to 10% uptake in the apical and the inferior apical regions, which is basically at this location. So another important question is, like, when you have an FDG uptake, do you have really a cutoff after which you say, oh, I mean, it's more than 10%, so that's reasonable to improve outcomes or to improve LV function? Usually what they used historically was 10%. I mean, the more the viability, obviously, the more the chances are to have a recovery in function. If it's, let's say, 5%, it might not be reasonable to proceed with the high-risk PCI or high-risk revascularization to secure that area on. So, and that it's a tricky question usually, whether, like, should I revascularize if they have lower FDG uptake? And I couldn't really find an accurate cutoff to follow. So what happened is the patient underwent staged PCI. First PCI was to the distal RCA, as you can see here. And then after like 4 weeks, he underwent mid-LAD CTO PCI. And he was admitted for a few days, continued his medical treatment, and was discharged to follow up in clinic. So overall, in terms of conclusions for my presentation, is still viability assessment is a potential tool for to guide revascularization, but we obviously don't have clinical trials that are well defined with well-defined techniques, and they are still needed to clarify the clinical benefits. The viability assessment techniques, one of the important take-home messages that I learned from this is nuclear-based tests are more sensitive, and the contractile reserve techniques have higher specificity. And that's it. Thank you. These are my references. Thank you.
Thanks, Hassan. That was a nice review of a very complex topic. Dr. Walker has a question in the chat. She asked for the prior studies that were evaluating viability. Were the patients symptomatic, like they had angina on meds, or were they mostly low EF and sometimes asymptomatic?
It was mostly low EF and asymptomatic. Because the studies are not really well defined, and the patient groups are not really randomized for the study, so it's hard to tell. But most of the ones I've seen were like no angina, and some of them were already planned to get cabbage for something else, and they had a viability study. But yeah, it's mostly asymptomatic patients with low EF.
Yeah, that's interesting. I'm asking because I've heard a number of times, like, you know, if you have ongoing symptoms, then you have viable myocardium. So I'm just curious what you and others think. Your patient's interesting because I think the person had angina, and I'm wondering if that's potentially, you know, a subset of people for whom you might think, you know, obviously revasc and they might have hibernating myocardium.
Yeah, I think also the main reason is also symptomatic improvement. I mean, he was taking nitroglycerin as well, but he still having angina that was at some point on follow-up visits after they had the first PCI was also he was getting worse. So that's why they insisted on proceeding with the second PCI at least to improve symptoms. Whether that will improve LV function, I'm not really sure. It could be. But I'm not really, I wouldn't be surprised if it didn't. Or if it probably is not going to change outcomes. He's 84, he has melanoma, and he has other these comorbidities, which also have to be taken into consideration when we plan our revascularization, especially if it's cabbage.
Looks like Dr. Devaretti also has a comment in the chat. He says, this is an area of CV science practice where I feel we are still in the dark. The methodology of viability assessment in these studies is suboptimal. It's unclear if the threshold of viable territory was appropriate, and many of these patients are now referred for high-risk PCI, as the surgeons don't want to take on the risky patients in light of their quality reporting. Need better trials with modern definitions, techniques, and incorporating PCI as well.
100%. That's basically what I learned from the kind of the bottom line of the topic. It's we're still in the dark in this, and we need more studies.
I'd be really curious to know how our heart failure transplant staff, use viability. I know, just for our patients that we end up referring at the VA to, Nashville for transplant evaluation, it seems to me that they will almost always try to intervene on, significant coronary disease, whether, usually by PCI, sometimes by cabbage, if they can, even though all of these studies seem to suggest that that is probably not going to help in the long run.
Hey, it's Laskar. I'll represent the heart failure opinion, even though it's a little bit crotchety. I think particularly if you are thinking about revascularization for heart failure and LV dysfunction without angina, and somebody who is capable of explaining those symptoms, as Dr. Chami mentioned and Devaretti, there's zero data to support that, both PCI wise and surgically. There are so many variables, including, does this guy look good? Are these coronaries, approachable from a percutaneous standpoint safely and all that? And those variables, in my mind, count more than the viability study and the viability of what it shows, because frequently, particularly out in the community or in practice or in places like at Emory and Emory St. Joseph's and Midtown, where our surgeons and our interventional cardiologists are so talented and amazing that they can fix just about anything. The idea that you're going to get benefit from a revascularization for specific segments is less based on what the imaging looks like and more on the other factors, particularly procedural factors. But yeah, to my mind, I don't think there's a trial that's looking at this question, even though in practice and out in the real world, people do this every day, all over the place, which is which it is what it is. But that's where things are.
Stan Sherman, did this patient after the second PCI get relief from the pain, and has there been an echo after all the interventional work that's been done to see if there has been any improvement?
So he had the second PCI, I think it was like on September 28th, and he didn't have any repeat echo afterwards. So I think still we need to check with the VA people in clinic to see what happened to him. It would be interesting to see at least his EF and his repeat echo and symptoms, of course. It's still too soon, I believe, for any functional recovery from this, especially he had a CTO procedures.
Great. Thanks, Hassan. Any other questions or comments?
Hello, hey, this is Steve Clements. That was a great presentation.
Thank you, Dr. Clements.
The EKG means something to my way of thinking. Like you have these big Q waves inferiorly or queued out all the way across the precordium. And you look at the echo and the walls are thinned out. That tells you something. That's the extreme of what you're talking about. And notice that one of your patients had a relatively thin anterior wall, and I believe it picked up a little bit. You always wonder about doing revascularizing these people, and we go through the motions with the FDG, which I think is helpful, and then sometimes they surprise you. But EKG influences us all also. We don't probably talk about it as much as we should, but I'll put that in the equation.
Yeah,
Stan Sherman probably believes that too, right, Stan?
Absolutely.
All
Yeah,
right.
that wasn't a queued out EKG.
Yeah, I mean, I totally agree, because like
That means something.
regardless of the evidence or not, there are some factors that favor whether we do viability. Let's say if you find like an apical aneurysm or very thin wall, Q waves, these are all findings suggestive of more of a myocardial infarction and less likely viability. So that's why when I said individualized approach, because when you have all these findings in a patient who's going to have a complex procedure that's also probably risky, then you probably don't need it with these factors that are there. But yeah, 100%.
Great. Thanks, Hassan. That was a really nice review, and I guess we'll wrap up a couple minutes early. Thanks, everybody. Have a great weekend.
Thank you. Thank you.
The preceding program is copyrighted by Emory University.